Greetings, good morning. This is our 30th session. And I want to thank my mentor, John Stolline, Mr. Charles Butt, Angela Dale, and my institution. So this is an interesting story. And actually, for the sake of fellows, it's a good idea to review the cases once in a while, to sit back and look at it because you learn quite a bit. And I've done that this morning. And So this is somebody in their 60s with a history of hypertension and hyperlipidemia, and also atrial fibrillation on Eliquis, with a family history of colorectal cancer, mother in late 70s with colorectal cancer, and brother with pancreatic cancer in late 50s. So I've been taking care of this gentleman for the last 5 years. And here is the summary. In 2000, he's been having colonoscopy since 2005. 2005, we had 1 tubular adenoma. 2007, 4 tubular adenomas. 2011, 1 tubular adenoma. And 2014, we had 2 tubular adenomas and 2 SSAs. And at that time, they found a flat lesion in the descending colon, and they felt uncomfortable to resect. So that's when I came into helping him. So in 2015, we did an EMR. It was a large sessile serrated adenoma. Actually, it was tethered. I suspect that it was partially cut before, but we were able to resect it. But we had to use like a little bit of piecemeal resection and then ablate the edge. And at that time, I removed another tubular adenoma. One thing is when I see somebody who is referred for a resection, I don't spend a lot of time trying to clear his colon because I want to take care of the problem. So in 6 months later, we went back to check the scar, and the scar biopsies were negative for recurrence. And at that time, he had 2 more tubular adenomas and 2 hyperplastic polyps. So typically after EMR, I do examine the colon at 6 months, and then again a year after that is 18 months after the resection. So that is 2016. We removed 3 tubular adenomas and 1 SSA. And so he was not comfortable having the exam done later than 2 years. And he insisted, okay, let's do it at 2 years rather than 3 years. So in 2018, he had 4 tubular adenomas. And all the tubular adenomas that were resected were small, less than less than 5 millimeters. So that's your story. Given the story, let me ask us, we have 2 people here with special interest in high-risk cancers, Sylvia and Selvi. So, Selvi, what are your thoughts? And I want to hear Sylvia's thoughts, because it's not about just resection. We want to figure out how to manage the patients. And I want you to know this. Sometimes it's a good idea to do this, because when I was putting things together, I said to myself, let me check his chart, whether he has ever seen a genetics person so far. He has not seen a genetics person, but he has seen a colleague of mine for pancreatic cancer screening.
So Raj, oh, go ahead.
Yeah, go ahead.
Go ahead, Sylvia.
No, go ahead.
Okay. Of course. So I think it's nice that we're seeing the cumulative adenoma burden for this patient. And I think it would be nice and good quality care for the patient if more of us kind of did this, taking the time to go back through the chart and seeing how many, pre-cancerous adenoma or SSA type polyps have been removed in a patient in their lifetime since they've started a colon cancer screening program. So
go ahead.
Go ahead. I can't hear you.
Program, if a patient has 10 tubular adenomas in one exam, 10
Sarah,
or more.
You may have to take one step back because we lost you in between.
Oh, sorry. Okay. So I think what I started saying was it's good for all of us to get into the habit of doing a cumulative adenoma burden for each patient that we have in our colon cancer screening program when we're doing colonoscopy. You can hear me now, right, Raju?
Yeah.
Yes.
Okay. So, and going through and seeing how many adenomatous polyps patients have had, I think is important, not just going based on the last exam or the current exam, but the total adenoma burden, because I think it gives us an idea of how quickly patients are, each individual patient is developing these adenomas. In our institution, and I was saying Silvio can maybe tell us how they do it at her institution. Here in our clinical cancer genetics program, patients can be referred if they have more than 10 or more tubular adenomas in one exam or more than 20 lifetime adenomas. So if their cumulative adenoma burden is 20, then they can be referred for a genetics evaluation. Of course, we see everybody that is referred to us, but those are the patients 10 or more in one exam or 20 or more in their lifetime that would qualify for genetic testing for a polyposis syndrome. So I think it's important for us to look at the cumulative adenoma burden for these patients. I think that's all I wanted to say about that. Sylvia.
Yes. I think in my experience, this case also would qualify for further genetic examination because he has cumulative, as far as I see, 16 adenomas over 13 years. The criteria we use here, I mean the ESGE guideline and the British guideline are a little bit different. The patient should have more than 10 colorectal adenomas if he's in his 60s, or more than 20 if he is in his 70s. But more or less the same concept, multiple adenoma should be a sign which indicates further analysis. And regarding this case, because he also has a family history of cancer, although the person's first degree relative both are are older than 15 years. I think mother in her 70s, if I recall well, and the brother in his 50s. This will also be an indication for further genetic evaluation.
Okay.
And the differential diagnosis would be either a multiple colorectal adenomas syndrome, or a Lynch syndrome, or a multi-age-associated polyposis, which could be likely given the older age, or a serrated polyposis syndrome because of simultaneous presence of several sessile serrated adenomas. So this would be my differential diagnosis at this point.
All right. I just wanted to, first of all, thank you both. And I also want to thank my good friend, Norio Widow. He's joining us from Japan. It's actually at 1 o'clock for them. I'm sorry about the timing, Norio. I really appreciate you joining. Thank you so much. So, so we did this colonoscopy, and this is as I was coming up the ascending colon into the hepatic flexure. This is what I see. Maybe one of you could actually talk about it. Actually, Sriram is also here. Maybe Sriram can comment. Sriram? whether Sriram is okay.
He was on earlier, Raju, but oh, here he is. Joined late, no mic, he said.
Okay, all right. Maybe Noria wants to comment on this.
I think this is very smooth surface and kind of watery. So I think it is kind of sessile serrated lesion, I guess.
Okay. And I'm going to take you to how big is this lesion, and how do you describe the Paris classification?
So 1S about 5 to 6 millimeter.
All right.
Nice type 1.
Okay.
Yes.
So what I've done is I've taken this video and I wanted to play it a little bit better with NBI. And what do you think now?
So NBI, can I answer?
Yeah, please.
Yeah.
Thank you so much. Thank you for joining.
My pleasure, my pleasure. Thank you for invitation. So it's similar color to surrounding mucosa and no vessel dilation and a very smooth surface. So I think this is SSL, hyperplastic polyp, I guess.
Mm-hmm. So,
it was interesting, Raju, on NBI, it looks like the lesion may be larger than I initially thought.
Yeah.
It looks like it extends up higher than, yeah, right?
Right. So what I wanted to do is let's go back to the first video, right? And I wanted to show this because some of us may have, initially I thought that this lesion was here.
Mm-hmm.
Okay, you see the arrow?
Mm-hmm.
Right?
Yes.
That's what I thought was a lesion, right?
Right.
And then I thought that, okay, could I do a cold snare, right?
Mm-hmm.
And then as I took time to really examine, I thought that there is something else like a tail here, and there is something vague here,
mm-hmm.
right? And then so as I do the extension here, I see that, okay, this is more like what Norio commented, the lesion, and there is something a little bit flat compared to this spit pattern here. There is a little bit of a border,
mm-hmm.
and there is something going on.
Mm-hmm.
So when I saw that, I thought that, okay, probably not a good idea to do cold snare. Maybe I should do EMR. Norio, what would you do?
So, but maybe still, same, almost the same size to cap. So less than 1 centimeter. So maybe I am doing a cold snare under NBI.
Okay.
Under NBI, yes.
Okay. So actually, I just wanted to share with you, actually, Roy last week suggested to the group that he's going to talk about how to inject. And Roy could not join us. He had a couple of issues, so he couldn't join us. So I actually brought these slides to explain to the people how to inject. And there are a few things that you don't want to do, right? Most of us who have trained, basically we trained to do varicose injection. We used to get the needle close to the varix, maybe push the needle out and inject. That is could lead to problems, right? You could actually have the needle go out, and that might lead to an extramural injection. Instead, it's important to have the needle out so that the endoscopist has full control, and maybe a little bit of gentle poke will get into the submucosa, and then use what Roy calls about, came up with the term, the dynamic injection technique, where as you inject, you lift That means you look up and try to get a dynamic injection. So basically, there are 3 steps for injection. Step 1 is you poke very gently with your needle out. Step 2 is the assistant basically taps rather than injecting. And it's very important for the assistant to tap on the plunger so that small aliquots of fluid goes out at each step, with each step. And that way you can control what is happening. And in addition to tapping, it's important for the assistant to say how much has gone in, like 1 cc, 2 cc, 3 cc, so that the endoscopist knows what is happening. Otherwise, the endoscopist doesn't know how much has been injected. And the third thing is, once you are inside the submucosa and you're creating a submucosal bleb, as the bleb is increasing in size, it's a good idea to slowly lift the tip of the scope, the big wheel pushing down so that you could create the dynamic injection. So these are the steps to keep in mind to create a nice controlled dynamic injection. So here is what we did. We used a saline with a little bit of methylene blue, and it's important to flush the needle, otherwise you may create an air bubble. And as you can see here, we are getting into the submucosa. And then inject, tap, 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 tap. The needle has actually remained superficial, so we have to give a little bit of a plunge. And as you can see, we're injecting to lift it. So Norio, any comments on how to do injection? How do you train people?
So basically I'm following your instruction, injection and then control the needle direction.
Okay, all right.
And sometimes I usually inject one puncture point, not the multiple injection point, because it makes the blood very, too large and wide. Sometimes it makes it difficult to capture with a snare.
So instead of a mound, it becomes like a plateau.
Yeah, yes.
Right. That's a very good point. First of all, I'm very happy that you joined us. You are the best teacher. I really admire you and I've learned a lot listening to you. So the next is, what type of snare do you want to pick up? So Sriram? Noria, what type of snare do you like to use?
I think, as I mentioned, it's almost 1 centimeter large, so maybe 10 mm.
Okay. And what is your snare preference in your own endoscopy suite?
Recently we use Olympus.
That is
for hybrid.
That's both a cold and a hot.
Both cold and hot.
And is that what you're using for most of your small EMRs?
Yes, recently.
Right. And if you use if you use a Snare Master Plus, would you still do a hot snare or a cold snare on this one?
Because we already injected, so maybe I do a hot snare.
Okay. And what are your settings?
Endocut.
Okay.
So yes.
Okay. So what I did was basically I used actually a 15 millimeter snare because I was not sure Usually what I do is, if the snare is like a vertical thing, I ask the assistant to slowly open and turn my scope. If the snare is a vertical and you have a nice mount, it is very easy to cut by actually rotating your scope. You don't have to see if the snare is flat and then try to put it on top of it. And we use EndoCut Q, effect 3, duration 1, interval 1. And that's what we use for most of it. This is what I've learned during my trip to Japan. I visited Kobe at that time. I also had a chance to meet with Noria at that time. So any comments on the resection and the margin? And why don't I actually go to the next slide? Okay. Let's see. Okay. So one thing is, I want to ask Noria whether they would suck the polyp as we have done, or would they wait and get it through a net when you see something like that?
So maybe in this size, we also use the suction trap. Yes.
Okay. Okay.
In my practice.
Right. Okay. All right. And do you want to comment on the base and the edge?
I think it's clear.
Okay.
No remnant.
Right.
Looks like.
So
yes.
for the sake of fellows, basically when you do the resection, you want to look for at least 2 things. When you look at the base and you see nice blue, meshy submucosal connective tissue, you know that the depth of your resection is limited to submucosa. It's not gone beyond the submucosa to involve the muscle. And if you remember the excellent work done by Michael Burke, the work was published in Gut, actually looking at the depth of the resection and the risk of delayed perforation. So when you see submucosa like this, you could tell your patient that, okay, you are not at risk for perforation. The other thing is, so one is you look at the depth of the resection, and the second one is you want to document that the margin is clear of any polyp. So that's the other thing. When Noria said it looks clear, basically there's no residual tissue. And if there is a concern about residual tissue and it is macroscopic, that is quite obvious, then you want to consider resection rather than ablation. And in lesions like this, when there is a clean cut with a clean margin, I don't ablate. But if there is piecemeal resection, I always ablate, and I try to do that with an APC. Although recently, snare tip soft coagulation has been shown to be very useful as well. So the next step is, Noria, would you close this defect or leave it alone?
Lesion about around 1 centimeter, we don't close it, just leave it. Yes.
Okay. All right. So what we did was, I don't know whether you remember this gentleman has been on Eliquis, and when somebody is in Eliquis, what do? It's a direct acting oral anticoagulant. In that situation, would you leave it alone or close? This is in the right side column.
So maybe we can close it with a clip.
Okay. Okay. All right. So because because of the fact that he was in his late 60s, and the right side lesion size is not big, but because he's going to go back on oral anticoagulants, I decided to close, and this is what we did when for the closure. And what I try to do is, whenever I try to close so that we have a deep approximation of the edges, so that we could cut down the risk of delayed bleeding. Because these clips can fall off very quickly. And the most important thing is, although there is no data, the clip will only work if you can actually create a deep approximation, so that it stays there. A deep approximation means, in my own view, that is, you don't see any gap, open gap between the two blades of the clip. As you can see, we're going deep, and then we're trying to apply the clip so that the submucosal vessels are also occluded. So after the resection and closure, you also want to make sure that you have a nice approximation. And so we restarted his blood thinner 24 hours later, and he has done well without any adverse events. And the pathology came back as Noria suspected, sessile serrated adenoma. Margins were clear. So that's the news. So any comments, Noria?
So in our practice recently, we use underwater EMR for sessile serrated adenoma. It make it really polypoid under the water, and it facilitate capturing the lesion. So that is just a practical comment.
So how do you do that?
So
you inject?
No, without injection. We deflate the lumen and then infuse the water and fill the lumen with the water. So under the water, usually flat lesion become polypoid. So even sessile serrated adenoma can be delineated very well as a polypoid lesion.
And do you do underwater cold or hot?
Hot.
Hot. And
yes.
The settings are the same?
Setting the same, yes.
Okay. And the snare is the same?
Snare is the same.
So it looks like your preference is now Snare Master Plus.
Yes, yes.
Actually, it has actually helped. That's
Raju, may I ask a question?
Please.
Would you consider in this case with multiple colorectal polyps in the history and also sessile serrated adenomas or polyps, would you consider pancolonic chromoendoscopy to better phenotype this case? I know there is a lot of discussion about chromoendoscopy, but I think these cases with multiple colorectal lesions may benefit from chromoendoscopy. It helps us to better determine the phenotype.
Yeah, I'm glad that you brought it up. I think the next step is for this patient to see Selvi, for her to do the genetic studies, and also the next time we could consider that. I have to share this with you, and I wanted your people's input on this. I do spend a lot of time examining the colon, probably one of the slowest guys in my group, if not the slowest. And as a principle, it is at least what I've learned from Roy is I'm actually using a very circular motion and try to look at the wall with my cap almost touching the wall, you know, almost, it's not touching like, and those that I thought that I should do chromoendoscopy and actually do chromoendoscopy, one thing that I do is I go in first, examine like the way I do, and then go back and do the chromo. I've not seen things that I've missed with white light.
Okay.
Especially with the 190 series, where the lighting is much more bright. And mentally, I'm looking for changes in groove pattern and the changes in the vascular pattern. I have not seen that I'm picking more with chromo. I wanted to hear what other people do. And the other thing that I notice is when I do the chromo, once I inject and then try to look for things, for some reason, every time I inject and then a puddle comes down and then I have to suck, by doing that, the colon tends to go into spasms. And this is what I see in practically. And so I wanted to hear what others would do. And how do you do that? Sylvia, how do you normally do your high-risk case examination?
I think that this is a very important question. And to be honest, in the early phase, when I started doing endoscopy, chromoendoscopy was my second teacher. So it helped me to better delineate the lesions. It improved my adenoma detection rate, but beyond a certain point, we may not have so much benefit. And I very much agree with your approach. Chromoendoscopy might be very helpful in the beginning. And actually, I'm happy that this hypothesis has been demonstrated recently by the Spanish randomized controlled trial in patients with Lynch syndrome. It was a non-inferiority trial, which finally showed that high quality white light endoscopy is not inferior to pancolonic chromoendoscopy in detection of adenoma. But all the endoscopists who participated in this trial were experienced endoscopists, dedicated endoscopists. So I very much agree with this approach. In the beginning, when we don't know a patient very well, so actually by index colonoscopy, when we see a lot of lesions, we still prefer to use pancolonic chromoendoscopy with indigo carmine to maximize the output and better phenotype the patient, because this will have repercussions for his referral to genetic department. If he doesn't have enough lesions, we will say, well, we will wait another 2 years. But if he has, let's say, instead of 9-11 lesions, we will refer the patient to the genetic department and they will do additional molecular analysis.
Okay. Let me ask, I really appreciate your input, and I'm glad that to hear, actually, I just briefly read that paper, the one that you're suggesting. Let me ask Selvi. Selvi, what do you do when you see patients with HNPCC or attenuated FAP? Do you make sure that you routinely do chromo?
So, Raju, I think I have the same experience that you do in terms of doing, mechanical chromo, I call it, spraying the mucosa, suctioning up the puddles, and then examining the mucosa for flat lesions. So in patients with FAP, so it's two different things. So patients with FAP, I don't generally do chromo, whether it's luminal chromo, mechanical, or electronic chromo, only because those lesions are sessile and it's hundreds of lesions and they're all sticking up in the air. They're all 1S lesions. So I don't look for flat polyps. And generally for those patients, it's more adenomatous polyps than SSAs. patients with Lynch syndrome or HNPCC, I think there's a couple of caveats that people need to remember. I think the prep needs to be pristine in order to do mechanical chromo. And I find my preference is really to do NBI, to do narrowband imaging electronic chromo, because I feel like I generally have a good eye when I'm doing white light, high definition scopes. And then using the NBI is just an extra tool that I can use. So I generally try to pull through. I examine on the way in white light. I try to pull through back from the cecum using NBI as long as the prep is acceptable. And I look for lesions. So I kind of do 2 exams. And I'm not a huge fan of, dye spray. Just because I feel like you're spraying and then the concentration is different. So sometimes it's very blue, sometimes it's not blue enough. And then you're always kind of cleaning up after yourself, and then the colon starts spasming. And I feel like it's more of a distraction. If I use that time and effort just looking with NBI, I feel like I'm getting a higher yield. That's my preference. It may not be the right answer, but that's what I do.
Let's hear what Naria, what do you do, sir?
In my practice, the same. I also use NBI observation. But I want to ask, do you use panchromoendoscopy, put the indigo carmine in from the syringe flash, or put the dye into a water pump?
In the water pump.
Oh,
yeah.
I see.
In the water pump, yes.
How about you?
We usually use just a syringe flash, so we don't use panchromoendoscopy much. So, but I read the literature about the method, put the indigo into a pump. I think it's very, useful, easy technique.
When you say syringe pump, is it a syringe attached to the biopsy port and flushing?
No, just a syringe flash.
Without a catheter?
No.
Without a catheter, okay. So actually there are, I see that there are quite a few trainees on this listening to this session. What I would, I want you to keep this image, right? You don't see any bubbles. The colon mucosa looks clean. So get into the habit of, as you go through the sigmoid, descending. So once you go into the sigmoid, it's not a bad idea to see, okay, if there are bubbles or whatever, flush a syringe of simethicone, water with a little bit of simethicone into the sigmoid colon. And as you go up into the descending colon, about the splenic flexures, flush again, and get into the habit of suctioning whatever you have actually put in. And it does 2 things. One is it will keep your left colon nice and clean as you come back to examine. But without your knowledge, you will also realize that you are straightening the left colon by doing that maneuver, so that your insertion would be very easy. And I do the same thing when I go to the hepatic flexure, another flush, because if you put it into the hepatic flexure or proximal transverse colon, and the patient is lying on the left lateral position, the simethicone will come down the transverse colon again into the splenic flexure. As it comes down, it clears up. The key is when you're thinking about screening colonoscopy, it's a great opportunity for you to prevent colon cancer. And the only way you can prevent colon cancer is to have a clean mucosa, which is free from bubbles, and it is relatively dry so that you can examine the mucosal vascular pattern and mucosal groove and pit pattern. So get into the habit. It's a very simple thing, but like anything else, unless you make a habit, it's not going to come one day. All right. So any other questions? So Sriram actually talks about he's using endo rings from US Endoscopy for high-risk screenings and polyps in difficult locations like around the flexures or behind the folds with very good results. It helps in withdrawal and flattening the folds. Maybe Sriram, I think it will be a good idea if you could actually record a video and bring it so that people can learn from that. You know, I've not used that myself. Maybe I don't think anybody at Anderson has used that. Maybe other people can comment if anybody wants to comment on that. So the other thing is I wanted to share just for the sake of the people's people who have joined us. This is a gentleman who had family history of colon cancer and also pancreatic cancer. And we are planning to get the genetic studies. And he had one of my colleagues, Dr. Jeff Lee, who has a special interest in pancreatic cancer screening. He did his initial evaluation, and it looks like he has IPMN changes in the pancreas on screening. So Jadish actually asked, can you use glucagon or buscopan to help with the spasm of the colon? Jadish, we used to use buscopan actually when I was in India and also in England. Buscopan is not available in this country, so we do use glucagon. That's what we use. And let me ask others. Noria, what do you use for colon spasm in Japan?
Yeah, same Buscopan.
Buscopan. How about you, Sylvia? What do you use?
Buscopan, but just rarely if it is a really spastic colon. Otherwise, we try to adjust by change of position, by other factors, and if it doesn't work, Buscopan 10 milligrams.
Right. One thing that is very important is, to educate the patients to do the prep right. And if they do the prep right, and nowadays what I'm telling my patients is, we all do the split dose prep, but if the patients that I see in the clinic and schedule them for colonoscopy, I tell them to buy some simethicone tablets. They're available in the US as Gas-X. And I tell them to chew Gas-X after their last, during and at the end of their second drink, or when a second drink means the split dose, second dose, 6 hours before. And with that, I've noticed that I don't see that much of bubbles. So that is something that I started using. And if they have a clean prep and you are gentle with your scope, you don't have, the colon stays quite lazy, and you don't have to worry about contractions. And the problem comes when you have a suboptimal prep and you are trying to clear, you will have a lot of contractions. That's why we should go back to the patient and say, hey, you need to do the prep right so that you have the best exam. Mohammad Asi's retroversion in the cecum routinely recommended. Let me ask
thank you.
Sylvie.
Yes, Raju. So the studies have shown that doing retroflexion in the right colon to evaluate the right colon is just as good as doing a second view, doing 2 views of the cecum and ascending colon. That being said, I routinely retroflex in the cecum/right colon. I do a first pull through on the right side making sure that I didn't miss anything. And then just to kind of double check myself, I'll retroflex in the cecum right colon to make sure that there's nothing on the backs of the fold that I missed. And I do find diminutive lesions on the backs of the folds. So I think it's a good habit for me. That being said, I will try once or twice, and if I feel like there's resistance, then I will abort the maneuver. In older patients, say, ones that are 80 and over, I generally will not try to do that because I feel like their colon is not as resilient.
Stairs. This is annoying to me.
And so I don't do that. And then if the sigmoid was very fixed and it was difficult to get through, then I'll I won't do the retroflexion either. So I kind of choose my patients wisely, and I don't try to force the issue, but if it goes easily, then I do that. And I don't just retroflex. Once I've retroflexed, I'll pull back and make sure that, I've examined not just the cecum or the back of the ileocecal valve, but also several of the ascending colon folds. So once I've pulled back and I straighten out, I find I'm always, in the transverse colon. So I feel like I've examined the entire ascending colon on the backside as well.
Okay, that's good. That's good. Thank you, Selvi. Let's find out. Actually, I'm glad that I'm asking too many questions to Noria, but I wanted to find out. Do they do that in Japan routinely?
For routinely, not much. I usually double check 2 times, observe right side colon 2 times, but seldom do retroflex. But as such kind of high risk patient, it was doing, but routinely, not so much.
Okay. So what I do is I use a cap at the end of the scope routinely for all colonoscopies. And the cap does help in pushing the folds or withdrawing the folds to examine. That's what I do. Sometimes if I don't use a cap, like say, for example, on Friday, I could not use a cap in somebody who had a rectal cancer surgery with a coloanal anastomosis, and I could barely put my index finger through that anastomotic area. So I had to remove the cap to put my scope in, the pediatric scope. So I feel a little bit uncomfortable to scope without the cap. So in that case, I actually did retroflexion. So there are cases where you could do. One thing that I want the fellows to keep in mind is it's a good idea to really check the tip deflection before you put your scope in. And if you get your large wheel all the way deflected so that the tip is deflected up, and your tip is only, say for example, you should deflect all the way back to retroflex, and if it doesn't, and that's not the scope that would help you to do retroflexion in the right colon. So something to keep in mind. The other thing is, when you have certain areas that you cannot examine, maybe not a bad idea to rotate your scope and use your tip deflection up to go back and examine certain walls. Is something to consider. So a few things to keep in mind. So Jaydesh asked, is there a way that we can control the way how the cold snare opens inside the colon, like vertically or horizontally? I don't know. I've not tried that. But to me, if the cold snare comes vertically, that makes my job a little bit easy. Think about holding your tennis racket, right? You can actually, if it is like a little bit of an angle vertical, right? And you can control that vertical movement either to the left side or right side by controlling or rotating on your scope shaft. And then you can actually move that. That only works if you can reach the cecum with your scope in a very short scope position. If you have a lot of loops, basically you are going to hurt your wrist trying to rotate the tip of the scope. So something to keep in mind. Mohammed asks, is the adenoma growing is faster in Lynch syndrome patients? Maybe Sylvia can answer that.
Sorry, can you repeat the question?
So Lynch syndrome patients, do the adenomas in those patients grow faster than somebody without Lynch syndrome?
Yes, that's a very good question. There is a 2010 study in clinical gastroenterology and hepatology showing that the dwell time for adenomas in Lynch syndrome is about 35 months, so 3 years, which is much less than the average dwell time in low risk and average risk population, which is 10 to 15 years. So the adenomas in Lynch syndrome are often non-polypoid and they grow much faster. So this is the take-home message, I think, for the trainees. We have to pay special attention to detection and to focus on subtle appearing lesions, because they will grow very fast. Once we miss a lesion, they will come back with an interval cancer.
All right. All right. So first of all, I want to thank everybody for your support and hope you all have a nice Sunday, rest of the day, and stay safe from COVID. I will see you next week. Thank you.